Good morning, everyone. First of all, Happy New Year, and thanks for joining us on the January 2016 IMEDS community call. My name is Christine Yu, and I work on the IMEDS program here at the Reagan-Udall Foundation. Please note that we are keeping this presentation on mute for the audience for the time being to cut back on the background noise. We will be taking everyone off mute at the end, so then we can have a short question-answer period. Just one quick announcement before I turn the presentation over to Dr. Swanson. We will be sharing with you in an email the results of a survey that was sent to our lab users in December. We received a lot of great feedback, so thank you to all those who participated. And for those who had asked to be contacted, we will be sending you a separate email sometime next week. So with us today is Dr. Sonja Swanson from Erasmus, MC, and the title of her presentation is Instrumental Variable Methods in Pharmacoepidemiology, Some Considerations. The slides for this presentation were sent out yesterday, and you should also be able to see them on your screen. We'll be posting a copy of the presentation along with the recording on our website afterwards as well. With that, so Dr. Swanson, thanks so much for joining us today, and I'll now turn the presentation over to you.
All right, thank you so much. Just making sure you can hear me all right?
Yes.
Okay, great. So thanks again for hosting me. I'm really excited to present some thoughts on the use of instrumental variable or IV methods in pharmacoepi. So this talk centers on a commentary that I wrote with Miguel Hernan on the reporting of IV methods, in which we did this literature review of how IV methods were being used in comparative effectiveness research. From doing this review, kind of my general takeaway was that as a whole, at least, studies rarely gave sufficient information for readers to critically evaluate or interpret the results that they were presenting. And so as unambiguous communication is really critical for science to move forward, what I'd like to do today is just focus on this theme of transparency. So while our commentary, we offered some suggestions on how to report IV analyses, what I'm going to do today is also give a little bit of a flavor of how to read an IV analysis report and what maybe to ask for that's not always included. I'm of course going to focus on our own suggested reporting guidelines from this commentary with Dr. Hanan, but I do want to point out that there's several other good resources out there for those that are interested in learning about IVs. And I put a couple of those at the bottom of the screen here. So given that I'm expecting a sort of heterogeneous audience here, I want to describe a little bit about at least what my goals are for this session. So for those who are less familiar with IV methods, I hope that, in general, I'm helping increase your understanding of how IVs work and what the major strengths and limitations of these methods are. And then, as I already alluded to, kind of provide some context on how to read an IV paper. Of course, given the time and the venue here, this is not going to be a tutorial. It's not going to be a comprehensive overview of these methods. And then on the other hand, for those who are familiar with or maybe even actively use IV methods, the themes that I discussed today should hopefully be ones that you're already grappling with in your own research. But I hope that by going through this presentation, you'll be at least reminded of or become more mindful of some of the key barriers in interpretation and in terms of promoting transparent reporting. So this brings us to why use IV methods? What are we even talking about here today? So if we're interested in estimating the causal effect of some treatment decision using observational data, we know that most of the methods that we're used to rely on an exchangeability assumption. That is, that we're able to measure and appropriately adjust for all of our confounders. This is a huge assumption, and certainly there's going to be cases where we're worried that it doesn't even approximately hold. For example, the confounding by indication might be so large that we're not really feeling great about using those methods. So in these cases, that's where the attraction of IV methods come in, because they avoid the need to even measure the confounders in the first place, that they can provide valid effect estimates even without measuring or thinking about the confounders. But of course, this isn't going to be a free lunch. This comes in exchange for several other strong assumptions. So what are those assumptions? Well, in brief, IV methods require investigators to propose a pretreatment variable known as an instrument that satisfies the instrumental conditions. These conditions include that the instrument is associated with the treatment, that it causes the outcome of interest at most through its potential effect on treatment, and that it's unconfounded with the outcome. All three of these conditions are encoded in both of the causal diagrams on the screen here, where Z is indicating a potential instrument, and we're interested in estimating the effect of treatment A on treatment Y. So again, both of these satisfy the first condition. In the causal diagram on the left, it's because Z is associated with A through some other shared cause. And in the causal diagram on the right, it's because the instrument directly causes the treatment. But again, both of them satisfy that first condition. And then in either of these DAGs, there's no direct paths from Z to Y or backdoor paths between Z and Y, except for the direct path through A and the DAG on the right side. So of course, the key to IV analyses is actually trying to find an instrument, trying to propose a variable that we think might plausibly meet these conditions. One of the most commonly proposed types of instruments in pharmacoepi is leveraging this idea of preference, of physician's or facility preference. The idea here is a physician, again, has some sort of preference or tendency to prescribe one treatment over another, and that preference is going to be associated with the treatment actually given to their patient. It should not affect the patient outcomes except through affecting the treatment strategy, and it should be unconfounded with the outcome. And then, of course, we don't actually have a measure of preference in administrative data, and so what we do is propose a proxy measure for preference that's based on how prescriptions were made to prior patients. So the most common proposed proxy is to just actually look at the last patient seen by that doctor for that indication and use that as a proxy measure for preference. There's, of course, other commonly proposed instruments out there. Most of them rely on kind of leveraging some sort of variation in terms of access to treatment, and I have a couple of those listed on the screen here. But for this talk, I'm going to mostly focus on preference as an example because it's the most commonly proposed, although some of the general statements, of course, apply to all instruments. So let's start first by considering condition 1, that the instrument and treatment have to be associated. So this condition is verifiable. We can check it in our data. And indeed, when we did our literature review, we see that it's almost universally reported on. So I don't need to dwell on this too much here. But one major consideration is that weak instruments can be problematic, both in terms of bias amplification and finite sample biases. On the other hand, there's this little bit of a funny trade-off in IV analyses because too strong of an association can also call into question any effect estimates. So just as an extreme example, if we were to propose an instrument that was perfectly correlated with treatment, then by definition it's going to be confounded by the same confounders as the treatment outcome relationship that we were hoping to avoid worrying about in the first place. And so again, we need to be mindful of weak instruments, but think through really how all of these conditions come together. So then let's turn to conditions 2 and 3, namely that the instrument has no effect on the outcome except through its potential effect on treatment, and that the instrument outcome relationship is unconfounded. So unlike in condition 1, these assumptions are not verifiable. We can't generally prove that these assumptions are going to hold. And so because of this, we really need to justify them using subject matter expertise, which requires thinking about these in the specific setting of our research question and our data. So the specific question about our proposed instrument, treatment, and outcome in question. There are some times that these can be falsified, that there's falsification tests, that can potentially find evidence against them. And so in terms of transparent reporting, then we really recommend that investigators should report on all appropriate falsification tests and then describe the theoretical justifications for both of these conditions. So we found from our review that there wasn't necessarily a lot of material on this in a given report. And so this is something that I think needs to be encouraged a little further. But beyond just simply reporting it, there are some general issues with IV analyses that go beyond thinking about these in the context of a single study. And that's that the violations can often be subtle and that the biases due to violations may not be intuitive. I'll talk about both of these points in just one second. So first, let's think about how these conditions might be violated in the context of physician's preference. So one issue would be if the physicians who prefer to prescribe treatment also tended to prescribe another co-medication along with it. And so if that other medication had effects on the outcome of interest, then preference may have an effect on the outcome that's not through the treatment of interest and therefore would not satisfy that second condition and not be a true instrument. Another example is if patients with similar characteristics tend to see the same physician. So for example, the more severely ill patients may tend to be seen by a specialist. In this case, because we're approximating preference based on prescribing patient practices to prior patients, preference is going to be confounded by these patient characteristics. I think that these two examples kind of broadly capture the major ways we conceptualize how preference may or may not be a valid instrument in a given setting, but there are also some subtle violations that we have to bear in mind. So for example, any IV analysis that's comparing the effect of one drug to another drug while ignoring other treatment options that might also be indicated can actually have a bias induced by selecting on treatment. And I think that this particular bias is fairly counterintuitive because restricting the analysis to the patients who take the two drugs of interest is actually something that makes perfect sense in a non-IV approach for this kind of research question. But in an IV study, it's essentially restricting on something downstream from the instrument and therefore can be inducing a selection bias. While I don't have time today to discuss all the ways that conditions 2 and 3 could be violated, hypothetically speaking, of course, I think something we need to grapple with in terms of transparent reporting is how to plausibly really justify these conditions when a lot of the violations can actually be quite subtle. Now, on the other hand, we can worry about how conditions 2 and 3 are violated, but like a non-IV analysis, you could argue that we never really think that we can measure all our confounders, so we shouldn't necessarily try to aim for perfection here either, that it might be okay with us if these assumptions at least approximately hold. Well, in the case of IV methods, this requires us to apply a completely different set of intuitions, heuristics, and quantitative tools for understanding what the direction and magnitude of bias might really be. So, for example, while in a non-IV analysis, we have decades worth of experience kind of thinking about confounding by indication or other sources of biases, we know how to discuss them, debate them, and perhaps even quantify them, their likely magnitude or direction. In an IV analysis, we need a completely different set of tools to think about these biases. One feature that actually makes this quite difficult is a known bias amplification property of IVs, namely that the magnitude of bias due to a violation of conditions 2 or 3 is also going to be a function of the strength of the proposed instrument. So because of this, if a proposed instrument is only weakly associated with the treatment, then what could seem like a rather minor violation of the conditions can lead to huge biases. And a corollary of this is that tools like covariate balance checks that were developed in the setting of non-IV methods to understand confounding bias may actually be quite misleading if they're inappropriately applied to IVs. So to see what I mean in terms of covariate balance, I'd like to show this reproduction of a report given by McClellan and colleagues in their seminal 1994 paper, which is sometimes considered the first IV application in the medical literature. So in this report, they presented the prevalence of a number of measured covariates by levels of the treatment and levels of the proposed instrument. And what we did in this graph here is we reproduced these as prevalence differences with triangles denoting the covariate balance or the prevalence difference across levels of the instrument, and circles indicating the covariate balance across levels of the treatment. So McClellan and others who have shown covariate balance in an IV analysis use this kind of information to suggest that the instrument is doing its job, that the covariates seem better balanced across levels of the instrument than the treatment, and it generally speaking, the covariates seem to be reasonably balanced, and that all these triangles in this graph are kind of centered around 0. What this sort of diagnostic check does not take into account, however, is that the relatively minor imbalances in the instrument can actually become more problematic. And so there's a number of ways we can incorporate this information into the diagnostic checks and presentation of results. So now on the screen, we have that same graph that I just showed on the left side, On the right side, we're showing the covariate balance scaled by the instrument strength, which might be a little bit better of a presentation to account for this bias amplification property. There's other ways that you could present this kind of information too, bias ratios and other kind of statistics like that. What I really want to stress here, though, is that although there's actually quite a bit of methodological literature out there on this bias amplification property, the reporting of IV methods still has not really embraced this knowledge into the best practices. So up to this point, I've only mentioned 3 conditions for IV analyses, but what I haven't really said yet is that an instrument is not enough. That if we stop at just these 3 conditions, usually all we're able to do is bound the average treatment effect, identify lower and upper limits that are consistent with it, but not necessarily a point estimate. However, most studies do not report bounds, even though this is something that I actually advocate for changing in the future, but most studies do just report a point estimate for their causal effect under a 4th or some sort of additional set of assumptions. And this, of course, leads us to the question, well, what 4th assumption are they making? What causal effect are they really estimating? So it turns out that there's a little bit of choice involved in the causal parameter we target using IV analyses. So if our interest is in the average treatment effect or the effect in the treated, then point identification requires some sort of homogeneity condition. And I have a couple examples of those listed on the screen depending on the modeling procedure used. Without these restrictions, again, the bounds that we're usually able to obtain tend to be quite wide. And I think that it's kind of generally agreed upon that these homogeneity conditions are pretty extreme and are rarely plausible for most of our research questions, although perhaps they're a little bit more plausible when we consider them conditional on measured covariates. So because of this concern over heterogeneity, most IV papers, when they're explicit, tend to estimate a different effect that only pertains to a subgroup of their study population. Again, I think one thing that's important to keep in mind here is that a lot of studies tend not to be very explicit of what they're even estimating when they're doing an IV study. But when they are explicit, they tend to interpret it as the effect in the so-called compliers or a local average treatment effect. So before I tell you what the definition is of a local effect, I want to give some examples of how these get reported. And for those in the audience right now who are pretty familiar with IVs, I want you to try to take a step back and just imagine that you're one of your clinician colleagues who's never heard of an IV before, has never taken a course devoted to IV analyses before, that you're really seeing these kind of fresh for the first time and reading a clinical paper. So these quotes say that the reported estimate pertains to, quote, patients who are marginal from the standpoint of the IVs, or a little bit more explicitly, the marginal patients whose treatment status can be affected by the instrument. So again, thinking about this, if you had no experience with IVs before, do you think that these presentation of estimates can really be interpreted judiciously and accurately by people not familiar with IV methods? So now let's turn and try to be a little bit more explicit about what these statements really mean. And so to consider these interpretations, let's first turn to the concept of compliance types. So for any dichotomous causal instrument, we can conceptualize our study population as belonging to one of 4 mutually exclusive groups or compliance types based on how they would be treated under each level of the instrument. So to ground this in an example, let's consider physicians' preference as an instrument and describe compliance types in the context of patients who could have either seen one physician, Dr. A, who generally preferred treatment, and another physician, Dr. B, who generally preferred no treatment or a different treatment. So patients who, regardless of whether they had seen Dr. A or Dr. B, would always end up getting treated, we're going to call an always taker. Patients who had, regardless of which doctor they'd seen, they wouldn't receive treatment, we're going to call a never taker. And then patients who, had they seen Dr. A who preferred treatment, they'd get treated. Had they seen Dr. B who preferred no treatment, they'd get no treatment. We're going to call a complier, that they align with the preference of the physician. And then finally, those who would get treated the opposite of the preference. So had they seen Dr. A, they'd not be treated. Had they seen Dr. B, they would get treated. We're going to call it defier. So they're getting the opposite of both of these preferences. Now, under what's referred to as a monotonicity assumption, the assumption that there are no defiers, it turns out that we can estimate the effect in the compliers. And this is, again, what's kind of referred to as a local average treatment effect. One thing that we can observe right away is that this is a subgroup that we can't identify. So we're estimating an effect in those who, had they seen Dr. A, would get treated, had they seen Dr. B, would not get treated. But because we don't get to see both of those counterfactual treatments, we don't know who the compliers are. So someone that actually saw Dr. A and was treated, they could be an always taker or a complier. We generally don't know. On the other hand, we can estimate the proportion of compliers and describe some relative characteristics of the compliers under the monotonicity assumption. And so I think this is an important point to kind of step back and think about the meaning of this effect and whether it's something we really care about, because it's not directly lending itself to targeted interventions, but there are some mitigating factors here. But let's think about these compliance types even more deeply for preference. And to illustrate some of the issues that come up, I want to give a little bit more background to the prescribing patterns that Dr. A and Dr. B give, hypothetically speaking. So let's suppose that Dr. A, again, usually preferred to prescribe the treatment and did this for most of his patients, but made exceptions for patients with diabetes. Perhaps he or she knew something about the presumed contraindications with the drug. And then meanwhile, Dr. B, again, usually preferred no treatment, but made exceptions for patients who were physically active, perhaps because of some benefit that he perceived with that. So in this case, any patient who is both diabetic and physically active would be treated contrary to both of these physicians' preferences and therefore be labeled a defier, which means that we have a violation of the monotonicity condition that's necessary to estimate the effect in the compliers. And because providers are obviously weighing many patient characteristics when they're making treatment decisions, I think that this shows that there's at least an opportunity for monotonicity to be violated when a physician's preference is proposed as an instrument. In fact, not only can we go through this sort of a thought exercise, but in the case of preference, we can actually to some degree empirically assess this by presenting the same cases or perhaps hypothetical patient reports to multiple physicians and measuring their preference in treatment at the same time. And this is actually something that we do in the epidemiology paper referenced at the bottom of the screen here, where we surveyed physicians and asked about their treatment plans for some hypothetical patients. And indeed, we found that there were some monotonicity violations. But another issue that came up with defining compliance types and actually in doing the survey is that, well, surprise, surprise, we live in a world where there's more than two physicians, and also those physicians can disagree. So two physicians with the same measure level of preference might not necessarily agree on how to treat a given patient. So in this case, without further information on who can be seen by whom, the compliance types are not really well defined. And then finally, all of this discussion really presumed that preference is a causal dichotomous instrument that's measured without error. And if we try to relax that a little bit more and more realistic interpretation of it, the interpretability of a local treatment effect gets even messier. So to summarize some of these key points that require special care, monotonicity may not be really a reasonable assumption for many commonly proposed instruments, like preference, for example. And then the compliance types may not really be that well defined. Finally, even if we were to put aside some of the messiness that can occur when monotonicity is unrealistic or the compliance types are ill-defined, I think it's important for us to reflect on what to make of this effect in the compliers, to really grapple with its interpretation and its possible meaningfulness from a decision-making perspective. So let's consider one of the common arguments for reporting local treatment effects. So the argument goes that, well, this effect might not be our first choice, but it's perhaps still going to be useful. And there's often this analogy made to other kinds of subgroup effects. So for example, if we had results obtained from a male-only randomized trial, we wouldn't suggest throwing away those results. Well, to think about whether this rationale applies to local treatment effects, let's think about why we might be interested in the results from a male-only trial. So on the one hand, we might be interested because we want to inform treatment decisions for men only. So we have these results from men indicating a certain treatment recommendation we want to make, and we're going to apply those results to informing treatment decisions for men only. On the other hand, maybe we're willing to believe, or we have some other evidence supporting that the effect is going to be similar in men and women. And so then even though the trial was only conducted in men, we're willing to transport the results to women and therefore inform treatment decisions for both men and women. So let's think about whether each of these rationales makes sense when estimating local treatment effects. So first, the idea that we could target interventions to just men doesn't really apply here to thinking about targeting interventions to just the compliers, because we don't know who the compliers are. We can't identify the compliers in our data set, so we can't target or suggest targeting treatments towards them. We also probably shouldn't extrapolate from the compliers, because heterogeneity was actually the whole reason we estimated a local treatment effect in the first place. So I think that it's common to see some circular reasoning out there where an effect is estimated in the compliers only because we think there's too much heterogeneity to responsibly estimate the average treatment effect. But then we try to justify extrapolating from this local to the global treatment effect, assuming that there's no heterogeneity. And again, I think that this is something that we need to think a little bit more deeply about in terms of our reporting standards. Now, one mitigating factor here is that we can somewhat describe the compliers. Even if we can't identify them, we can know what proportion of our study population are compliers, describe them with respect to some measured characteristics in relative terms at least. And so perhaps in some settings, there may be a little bit more reason why we'd be interested in this effect than in others. So with that all in mind, I'd like to review the reporting guidelines we had, which were depicted in this flowchart here in the paper. I'm going to go through these relatively quickly because the themes of everything in this flowchart is now what I've covered in this talk to this point. So first, we recommended reporting on the association between the proposed instrument and treatment, thereby verifying condition 1. And again, as I said, this was actually something that I think we're doing a good job of already in terms of our reporting. Then we suggest clearly reporting the theoretical justification for and any falsification tests relevant to conditions 2 and 3. And I think that there needs to be a little bit more detail provided in the sense of these. From there, we suggested being very explicit about the effective interest. And I think in particular for the local average treatment effect or other kinds of local treatment effects, justifying this choice is really key, that we need to explain why we're interested in this effect or how to meaningfully interpret it. We also suggest reporting bounds, which isn't something that I've emphasized in this talk, but again, this is rarely done in practice to this point, but perhaps something that we can talk about in the future. From there, if we're interested in targeting the average treatment effect, we need to think about the theoretical justification for the homogeneity conditions employed. And if we're interested in targeting the local treatment effect, again, we need to provide theoretical justifications for, or maybe even evidence supporting why monotonicity is a reasonable assumption. And then, as applicable, to report on the characteristics of the compliers, the proportion of compliers, we can obtain that. And then finally, if all of these steps are met in the affirmative, we suggest reporting on all of the steps, of course, and any further modeling decisions made in the analytic strategy. And that gets us sort of through this flowchart that we give in the paper. So finally, I'd like to think about these reporting guidelines and related IV reporting guidelines proposed by others in the context of how we should report on comparative effectiveness research in general. Because in some ways, what I'm advocating for here today is not really that different from what we should be doing more broadly. That it's not specific to IVs, but really IV and non-IV studies alike should be thinking about some of these themes. So, for example, we should always clearly state our assumptions. We should always give enough context, sufficient detail to discuss the assumptions and potentially debate the assumptions. And then, of course, we should be clear about what we're actually estimating. We should say how to interpret the results that we have under those assumptions. On the other hand, I think that IV reporting has to address some unique challenges in the way that we're thinking about subject matter expertise and the way that we can try to either heuristically or quantitatively think about biases requires some different perceptions. And then the interpreting these local treatment effects requires additional care. So with that, I'd of course like to thank my collaborators on various IV-related projects, Miguel Hernan, who again was the co-author of this commentary, as well as Matt Miller and Jamie Robbins, who have worked with me on other IV-related projects. And thank you all for your attention.
Wonderful, Dr. Swanson. Thank you very much again for taking the time to present to us today. So with the remaining time that we have, I'd like to just open up the call for a short question and answer period. I'll now go ahead and unmute everyone. So if you'd like to ask Dr. Swanson anything, please just announce yourself first.
The conference has been unmuted.
This is Alec Walker. Sonja, that was a very clear and lovely presentation. I have a question from a user's point of view. I would, in an analytic setting, I'm sometimes driven to think about doing an IV analysis because I'm concerned about unmeasured confounding in doing a direct analysis. And it seems to me that your guidelines would help me identify situations in which it would be reasonable to turn to an IV analysis without actually, before I commit a lot of resources to doing it. And could you speak a little bit, and I think this is related to the early tests that you mentioned, but could you speak a little bit to the situations in which I, as an applied epidemiologist, ought to be seriously thinking about an IV analysis and how I can see whether the setup that I've got is amenable to it?
Sure. I think that, first off, that's a great question. It's also a really difficult question to answer in the abstract without having kind of a potential IV already in mind. So I think there's kind of two layers of it. If you have a potential instrument that you think might be appropriate in your setting, I think that a lot of our flowchart could just be viewed as kind of the background that you should be doing in any kind of causal analysis where you're thinking about whether these assumptions really should hold before you do that analysis. So thinking about, unmeasured confounding in all of our other approaches versus here, it's just thinking really deeply about these assumptions. I find it a little bit harder to think about how you would come up with an instrument if perhaps this indicates my own lack of imagination, but if it wasn't already obvious to you what might be an instrument in a given setting, I don't have great suggestions on
I'm not asking that. I mean, let's say, hospitals differ in their formularies. And so to compare two drugs, I want to use hospital as my instrument. Without going through the whole process down to how I should report it, is there an exit point where I can say, I do this rather than just think about it? Are there data tests that I could do to say I can foresee this is going to be problematic, and I'll just stop and go into something else?
Yeah, so I think actually the ordering of our flowchart could be viewed almost as, rather than reporting guidelines, kind of what you should be doing step by step along the way. So, there's a lot of literature out there on how weak instruments are a problem. So perhaps the very first thing you would do is just check whether it's actually associated with your treatment.
Good.
And then from there, I think it does take some time to grapple with whether it's theoretically justifiable. I did allude to all these falsification tests, but I think that they tend not to find evidence falsifying them, and so you should still be very suspicious at that point, I think, as well. But if you look at the flowchart, which is why I went back to it here, we do kind of conservatively suggest that an IV analysis is inappropriate if you can't answer these questions in the affirmative. And so, yeah, I think you could interpret the same kind of step-by-step as from the applied standpoint, starting an IV analysis and thinking whether you should go down that stretch.
Thank you.
Yep, of course.
Great. Anyone else?
Yeah, hi, Sonja. This is Susan Gruber. Thank you for a really a nice talk. I don't use IV methods, and so I tend to get confused when I think about them, and this is very clear.
Thanks.
You're welcome. So I have a question about the monotonicity violation examples. When you were talking about, I know this is just an example, but that the Dr. B usually prefers to prescribe no treatment except if a person was physically active. That was the example. So in this case, the patient would be labeled as a defier, but isn't this really just that we got the IV wrong? And so is it possible to have like a more nuanced definition of the instrumental variable so that the preferences of the doctor in this case would be different in different patient populations? Would that screw up the instrument, or would that actually do a better job at reducing the violations of the monotonicity assumption?
Yeah, so I think that's a great question. I think that certainly, I gave this presentation at the very simplistic level where I'm not conditioning on any extra covariates, but you could think about incorporating those and then perhaps within levels of the patient characteristics, do you think monotonicity might hold a little bit better, or for that matter, any of the assumptions might hold a little better? I think the example with physical activity, though, might give some flavor of how this could be really hard in administrative data because, again, trying to think through all the patient characteristics that get towards preference or get towards treatment decisions in general are not going to necessarily be in administrative data. And so just like we worry about that in the kind of non-IV method strategies, I think that in the IV methods, we can get hung up on that too. So physical activity wouldn't necessarily be measured, although diabetes is and or usually is. And so therefore we could incorporate that into our definition, but not necessarily both in that example.
Okay, thanks.
And actually, just one other thing to add to that, I think that preference, as an example, to my knowledge at least, I've never seen a paper that incorporates those covariates into defining preference itself. So they might do an analysis conditional on patient characteristics, but they're not necessarily looking at the last patient seen by that physician who had similar characteristics as them. So that's another thing to keep in mind.
But there's no reason they couldn't, right?
Right, yeah, for the measured covariates.
Okay, thank you.
Yep.
Thanks, Susan. Any other questions?
Well, if nobody else is jumping in, this is Alec again, I do have another. I understand bias amplification when we control for an instrument and do a direct analysis. Could you give us some examples to understand bias amplification in an instrumental variable analysis?
Yeah, so I was aiming for this talk to not be too technical, so I did gloss over this. But if you think of the standard IV estimand, so the ratio of the, speaking loosely here, the effect of the instrument on the outcome divided by the effect of the instrument on treatment. So you have a ratio of these two estimates risk differences there. The denominator is going to be bounded by 0 and 1, right? It's or negative 1 and 1, I should say. So it's a risk difference of getting that correlation between the instrument and the treatment measured. And so if the numerator is off by a little bit, then it's whatever amount that's kind of getting misestimated is going to get amplified by dividing by this denominator. So if you have a really small denominator, things can blow up. I mean, I think it's really easy to see, again, when you're kind of considering just the standard IV estimate, but when you go to modeling settings, it can get a little hidden, of course, too.
Thank you.
Any other questions from anyone? Okay, great. If there are no more other questions, we can end the call early and give you back some of your time. So thank you again, everyone, for taking your time out of your schedule to join us. The next call will be on Friday, February 19th, and you'll see an invitation from us with the topic of that discussion soon. Thank you all again, and have a great day.